Hello everyone, my name is Dr Hester Lacey and I am the author of Crash Course Surgery 4th edition and the ClinicalKey Student Assessment Editor. Today we're going to be going through high yield SBA questions and content relating to core topics on the surgical UKMLA syllabus. Let's get started. I'll just quickly introduce myself. So I am the current editor for the ClinicalKey Student Assessment Platform, which is an international question bank covering core topics for medical finals across the world. Elsevier is a global publishing company, publishing books, well-known books like Grey's Anatomy and Kumar and Clark. And they also publish the Crash Course series of medical textbooks for revision. I am the sole author of Crash Course Surgery, which is about to release its 4th edition in this year. And Crash Course Surgery is complementary to this webinar covering core essential components of surgical content for medical finals. This is the overview of the UKMLA content map for surgery. These are the key conditions that you need to be able to recognise in SBA questions as a student and in clinical practice as a foundation doctor. Understanding of these conditions, including the presentation and appropriate investigation and management, will ensure you can excel in your exams and clinical practice. Several of these topics will be covered in this webinar. All information covered is included in NICE clinical knowledge summaries or guidance. Now we can begin with 10 questions covering core topics for the UKMLA syllabus for surgery. Question 1. A 38-year-old woman has 2 weeks of perianal discomfort, itching and discharge. She has Crohn's disease, managed with azathioprine. There is circular granulation tissue in the anal canal and mucopurulent anal discharge. Which is the most likely diagnosis? A. Anal fissure. B. Anal fistula. C. Anorectal abscess. D. Hemorrhoids. Or E. A pilonidal cyst. So I'll just give you about 30 seconds to read the question again and think about the correct answer. And here we have the correct answer, which is B, anal fistula. In the next few slides, we'll go over some key content relating to anal fistula and cover what makes that the correct diagnosis. An anal fistula describes an abnormal tract between the anal canal and the perianal skin. They most commonly develop after an acute anal rectal abscess that's been inadequately treated and leaves a residual sinus tract draining to the skin. Anal fistulae are classified depending to their relationship with the external anal sphincter. As you can see in this diagram, several different types of anal fistula are portrayed. Intersphincteric fistulas are the most common, and they cross the internal sphincter only before opening onto the perianal skin. Transsphincteric fistulas pass through both the internal and external sphincter, and suprasphincteric fistulas, which are much less common, cross the internal sphincter and then track upwards to pass through the levator ani muscle before then returning back to exit via the perianal skin. Extrasphincteric fistulas arise proximally superior to both anal sphincters. Key risk factors for anal fistula include inflammatory bowel disease such as ulcerative colitis and Crohn's disease, as we see in this stem, radiation proctitis, and anorectal malignancy. Symptoms include defecatory anorectal pain, anal itch, and mucopurulent anal discharge, but anal fistulae are notably much less painful than anal fissures. Signs on examination include granulation tissue and a palpable tract or cord in the anal canal, where the fistula itself can be palpated on digital rectal exam. There are clinical diagnosis, and interventional management is required to resolve the fistula, typically with surgical repair, with a fistulotomy with excision of the sinus tract, and setton placement, which maintains the fistula open to allow adequate drainage to promote healing, or glue. Moving on to the next question. So again, I'll read out the question and the answer options and then give you about 30 seconds to think about the most likely answer. A 65-year-old man is invited for routine abdominal aortic aneurysm screening. He has hypertension managed with ramipril. His blood pressure is 132/87 millimeters of mercury. His abdomen is soft and non-tender with no audible bruise. Investigations include an ultrasound abdomen, which shows a 3.5 centimeter dilation of the abdominal aorta. Which is the most appropriate next step? A. No follow-up required. B. Ultrasound after 10 years. C. Ultrasound after 12 months. D. Ultrasound after 3 months. Or E. An urgent referral to vascular surgery. Have a think about the answer. And here we can see the correct answer is C, ultrasound after 12 months. So now we'll just go through what makes that the correct answer. An abdominal aortic aneurysm describes the permanent pathological dilation of the abdominal aorta over 1.5 times the normal diameter, which is defined as under 1.5 centimeters in the ascending aorta and under 2 centimeters in the descending aorta. Risk factors for aortic aneurysms can be classified as non-modifiable and modifiable. Some non-modifiable risk factors include male sex, increasing age, and a positive family history. And modifiable risk factors: smoking, hypertension, diabetes, and chronic obstructive pulmonary disease. Here we have some imaging findings in abdominal aortic aneurysms. Ultrasounds may be used for the initial assessment of symptoms, followed by a CT angiogram to definitively diagnose the condition. On the CT, we can see a large aortic aneurysm exceeding 5 centimeters in diameter. The T denotes the large thrombus partially surrounding the contrast-enhanced patent lumen, L. And we can also see evidence of atherosclerotic calcification with the arrowhead surrounding the wall of the aorta, suggesting underlying risk factors for vascular disease. The abdominal aortic aneurysm screening program was introduced in the UK to detect asymptomatic abdominal aneurysms and allow monitoring of these aneurysms for growth and reduce the risk of subsequent rupture. The screening program involves a one-off abdominal ultrasound offered to all men aged 65. Those with a large aneurysm size are at increased risk of rupture, hence further monitoring or intervention is required depending on the size of the aneurysm found. For those where no aneurysm is detected, no further scans or follow-up are required, as the risk of subsequent development of a large aneurysm is low. For those with a small aneurysm between 3 to 4.4 centimetres, they are offered a repeat scan in 12 months. For those with a medium aneurysm, 4.5 to 5.4 centimetres, they are offered a repeat scan in 3 months. And for those with a large aneurysm, 5.5 centimetres or larger, urgent referral to vascular is required due to the risk of rupture associated with aneurysms of these size. So we can see for our patient, the abdominal aortic diameter was 3.5 centimetres, hence repeat scan in 12 months is the correct answer. Management of abdominal aortic aneurysms includes risk reduction in all those where an aneurysm has been detected, involving most importantly smoking cessation, as this is the biggest modifiable risk factor for vascular disease, diet and exercise, so a healthy diet and weight loss to within a healthy BMI range, and moderate exercise, and management of comorbidities including atherosclerosis, hypertension and diabetes, which may be with statins, blood pressure reduction according to NICE guidelines, and management of glycemic control. Surgical repair is indicated for large aneurysms, so above 5.5 centimetres. This is electively involving endovascular aortic repair or open surgical repair for those not suitable for an EVAR, including a very long AAA, excessive thrombus in the aorta, or occlusive peripheral artery disease where endovascular access may be contraindicated. Emergency repair is used for unstable patient or those with symptoms of impending or current rupture, including severe abdominal pain, hypotension, and a painful pulsatile mass. And the use of EVAR or open surgical repair will consider hemodynamic stability and surgeon preference. This diagram shows an overview of endovascular aortic repair. First, a guide wire is inserted via the femoral artery. A stent graft is advanced over this guide wire and positioned proximal to the aneurysm, with deployment of the first graft securing it in place and positioning the first iliac limb. A subsequent guide wire is inserted on the contralateral side. The stent is deployed at the top, anchoring the second stent into the aorta, and then the iliac extension is then advanced separately and deployed, anchoring both iliac limbs. The guide wires are then removed and the femoral incisions closed. Moving on to the next question. A 16-year-old boy has 2 days of abdominal pain, which began centrally and is now localised to the right lower quadrant, with nausea, vomiting, and loss of appetite. His temperature is 37.8, pulse 109 beats per minute, and blood pressure 131/74 millimeters of mercury. He has severe right lower quadrant pain, worse on palpation of the left lower quadrant, with guarding and rebound tenderness. Which scoring criteria will guide the likely diagnosis? It's A. Alvarado, B. Child-Pugh, C. Glasgow-Imrie, D. Glasgow-Batchford, or E. Rockall. So I'll just give you about 30 seconds to think about the correct answer. The correct answer is A, the Alvarado score, which predicts the likelihood of appendicitis, which is the underlying diagnosis in this question. The Child-Pugh score relates to cirrhosis mortality, The Glasgow IMRI criteria relates to the severity of acute pancreatitis based on 8 laboratory values. The Glasgow Batch Bleeding Score stratifies upper GI bleeding patients into those who are low risk and candidates for outpatient management. And the Rockall score is used pre-endoscopy in upper GI bleeds to determine severity. Appendicitis describes acute inflammation of the appendix. It is a clinical diagnosis made with key signs and symptoms. Typical features are abdominal pain, classically migratory abdominal pain that starts in the periumbilical area, that worsens and migrates to the right lower quadrant, becoming sharp and localized over 24 to 48 hours. Pain is worsened by movement and it's often associated with peritonitic features due to irritation of the peritoneum, presenting with rigidity, guarding and rebound tenderness. Other features include a fever, which is often low grade, general malaise, anorexia, nausea and vomiting, and constipation or sometimes diarrhea, and patients can experience urinary symptoms. There are several key signs associated with acute appendicitis, including Rosving's sign, where palpation of the left lower quadrant increases pain in the right lower quadrant, the psoas sign, where passive extension of the right thigh when in the left lateral position produces pain in the right lower quadrant, and the obturator sign, where passive internal rotation of the flexed right thigh elicits pain in the right lower quadrant. So the correct answer, the Alvarado score, predicts the likelihood of acute appendicitis, which is the underlying diagnosis in this case. The Alvarado score offers points for clinical features and laboratory findings, which suggests an increasing likelihood of acute appendicitis with an increasing score. You get points for migration of pain to the right lower quadrant, anorexia, nausea or vomiting, tenderness in the right lower quadrant, which scores 2 points as it is particularly suggestive of this, rebound tenderness, a fever above 37.3 degrees, leukocytosis, which again gets 2 points, and a neutrophilia above 75%, which gets 1 point. Scores below 4 suggests a low likelihood of acute appendicitis, and scores above 7 suggest a high likelihood of acute appendicitis. Appendicitis is typically a clinical diagnosis. Where there is diagnostic uncertainty, an abdominal ultrasound can be performed to confirm the diagnosis. Typical findings include appendiceal dilation, wall thickening, and the target sign, which is shown in this image as concentric rings of hyperechogenicity within the appendix. The management of acute appendicitis involves initial resuscitation with intravenous fluids and broad-spectrum empirical antibiotic therapy for intra-abdominal infection, and the gold standard of management is a laparoscopic appendectomy within 24 hours of diagnosis. Moving on to question number 4. A 67-year-old man has 2 weeks of a painless groin lump. He has a right-sided lump superomedial to the pubic tubercle that does not transilluminate, is reducible but reappears on coughing. Which is the most likely diagnosis? A. Direct inguinal hernia, B. Femoral hernia, C. Hydrocele, D. Indirect inguinal hernia, or E. A varicocele. So I'll give you 30 seconds to think about the most likely diagnosis. And here, the correct answer is A, a direct inguinal hernia. We'll go through inguinal hernias in more detail in the following slides. A femoral hernia is found inferolateral to the pubic tubercle and medial to the femoral pulse and is commonly seen in older females. A A hydrocele is an abnormal collection of peritoneal fluid between the parietal and visceral layers of the tunica vaginalis surrounding the testes. And a varicocele is an abnormal dilation of the pampiniform venous plexus in the spermatic cord. It presents with a groin lump that is often described as a bag of worms. An inguinal hernia describes protrusion of the abdominal or pelvic contents into the inguinal canal through the superficial inguinal ring. An indirect inguinal hernia describes protrusion of the abdominal or pelvic contents into the canal through the deep inguinal ring, whereas a direct inguinal hernia describes direct protrusion of the abdominal or pelvic contents through the posterior wall of the inguinal canal through Hesselbach's triangle. Hesselbach's triangle is described as being bordered medially by the lateral border of the rectus abdominis, superiorly by the inferior epigastric vessels, and inferiorly by the inguinal ligament. Inguinal hernias present with a groin lump superior medial to the pubic tubercle. These lumps typically increase in size with increased intra-abdominal pressure, such as coughing or straining, and decrease in size or reduce when lying flat. There may be associated vague scrotal discomfort, although many are predominantly asymptomatic. A direct hernia is reducible with pressure over the deep inguinal ring, but reappears on coughing as the hernia protrudes directly through the wall of the inguinal canal. An indirect hernia is reducible with pressure over the deep inguinal ring, but does not reappear on coughing, as this is the location of protrusion of the bowel contents. Indirect inguinal hernias are typically due to congenital patency of the processus vaginalis, as well as weakening of the transversalis fascia around the inguinal ring. Direct inguinal hernias typically result from chronic increases in intra-abdominal pressure, commonly seen in patients with a chronic cough, such as in COPD, or with heavy lifting. While inguinal hernias typically present with mild symptoms, there are several complications that you should be aware of. Incarceration, which describes the inability to reduce the hernia, presenting with severe pain and groin swelling. Strangulation, where incarceration progresses to compromising the blood supply to the herniated tissues, causing tissue ischemia, presenting with acute pain and hemodynamic instability. Intestinal obstruction, if the protrusion into the inguinal canal contains bowel contents, then the bowel can become obstructed, presenting with abdominal pain, vomiting, and gross abdominal distension. Inguinal hernias can recur after surgery, with recurrence rates of up to 15%. And chronic pain may develop pre- or post-operatively, lasting over 3 months in up to 10 to 12% of cases. Complications of inguinal hernias, including incarceration, strangulation, and obstruction, are indications for emergency hospital admission and emergency surgical repair. Management of inguinal hernias depends on the presence of symptoms and any associated complications. In asymptomatic cases, conservative management may be trialled in the first instance with a period of watchful waiting, though typically most patients managed conservatively will eventually require repair. Surgical repair involves elective open mesh repair or laparoscopic repair. This image demonstrates the placement of a mesh over the underlying weakness, and which results in resolution of symptoms. Moving on to the next question. An 82-year-old man has 2 days of colicky abdominal pain, which is now severe, with nausea and vomiting. He last opened his bowels 8 days ago. He has osteoarthritis managed with codeine. His temperature is 36.9, pulse 128 beats per minute, and blood pressure 115/78 millimeters of mercury. He has generalized severe abdominal tenderness and gross distension with hyperactive bowel sounds. And an X-ray film is shown over to the right. Which is the most appropriate management? A. An emergency laparotomy. B. A flexible sigmoidoscope decompression. C. Intravenous antibiotics. D. Manual stool disimpaction. Or E. Nasogastric tube insertion and intravenous fluids. So I'll just give you about 30 seconds to think about the correct answer. So the correct answer is E. Nasogastric tube insertion and intravenous fluids. Intestinal obstruction describes obstruction of the bowel lumen, which can occur at any point in the small bowel or the large bowel. Obstruction presents with the following symptoms: absence of the passage of flatus or stool per rectum, colicky abdominal pain and abdominal distension, anorexia, nausea or vomiting, which may be feculent, abdominal tenderness without guarding or rebound tenderness, and active tinkling bowel sounds, which is typical in the early stages, relating to the increased peristaltic effort of the bowel attempting to pass the obstruction. This may progress to quiet or absent bowel sounds as the obstruction worsens, and absent bowel sounds are a late sign. Risk factors include constipation, although this rarely results in complete obstruction. Small bowel obstruction typically relates to adhesions or hernias, and large bowel obstruction most commonly relates to malignancy. Imaging findings can help us differentiate between the location of the lesion in the small bowel or the large bowel. Small bowel obstruction presents with dilated central bowel loops on an abdominal film, and you can see the valvular coniventes traversing the full width of the bowel in the image provided associated with the question. Large bowel obstruction presents with gross dilation of peripheral bowel loops with haustral lines crossing only the partial width of the bowel, as seen in the image off to the right here. Dilation of the bowel is defined as over 3 centimetres of the small bowel, over 6 centimetres of the large bowel, and over 9 centimetres at the cecum. The diagnosis of intestinal obstruction is most reliably made with a CT abdomen and pelvis, which is the most appropriate test in hemodynamically stable patients with an acute bowel obstruction. A CT will demonstrate dilated bowel loops proximal to the obstruction and decompressed loops bowel distal to the obstruction, air fluid levels, and you may be able to identify the transition point where the obstruction is occurring. This image shows a mass in the proximal small bowel with decompressed loops distal to the obstruction. The management of bowel obstruction includes intravenous fluids and nasogastric tube insertion to decompress the bowel. Conservative management is often appropriate in the first instance and may be trialled for up to 72 hours. However, surgery can be used in complicated cases or where there is a failure of non-operative management. Indications for surgery include evidence of complications such as ischemia, perforation, or enclosed loop obstructions, which typically occur with a mass distal to the ileocecal valve, or if patients have refractory hemodynamic instability or underlying etiological necessities for surgical intervention, including hernias. Surgery involves an exploratory laparotomy with management of the obstructive cause such as adhesiolysis, hernia reduction or tumour resection, and resection of any gangrenous bowel. Stoma creation may be required in these cases. Moving on to the next question. A 68-year-old man has 3 months of increasing abdominal pain, nausea and fatigue with abdominal distension. He had left hemicolectomy for colorectal cancer 6 months ago. He is cachectic with conjunctival pallor, gross abdominal distension and generalised tenderness, with bilateral dullness to percussion in the flanks that becomes localised to one side when he lies on that side. Which complication has he most likely developed? A. Cirrhosis. B. Liver metastasis. C. Pancreatic cancer. D. Peritoneal tuberculosis. Or E. Peritoneal carcinomatosis. I'll just give you about 30 seconds to think about the right answer. So the correct answer is E, peritoneal carcinomatosis, and we'll go through why in the following slides. Colorectal carcinoma is the 4th most common cancer in the UK, accounting for 11% of all new cases of cancer. Risk factors include age, family history, genetic predisposition including FAP and HNPCC syndromes, colorectal polyps, which can undergo malignant transformation, smoking, alcohol and obesity. NICE recommend a fecal immunochemical test for patients with symptoms suggestive of colorectal carcinoma. This can include abdominal mass, change in bowel habit, or iron deficiency anemia in any patients. Specific referral criteria include those aged over 40 with unexplained weight loss and abdominal pain, those aged under 50 with rectal bleeding and unexplained abdominal pain or weight loss, those aged over 50 with unexplained rectal bleeding, abdominal pain or weight loss, and those aged over 60 with anemia even without iron deficiency. Patients with a positive FIT test of at least 10 micrograms of hemoglobin per gram of faeces should be referred for a diagnostic colonoscopy under the 2-week wait pathway. The NHS Bowel Cancer Screening Programme involves fecal immunochemical testing via the post. Bowel screening is offered every 2 years to people aged between 60 and 74, and those with abnormal results are further referred for colonoscopy under the 2-week wait pathway. Performing a colonoscopy allows for direct visualization of the lesion and biopsies for histopathological confirmation of the diagnosis. This facilitates TNM staging, which is completed with a CT chest, abdomen, pelvis to look for any metastatic lesions. Management of colorectal cancer involves an MDT approach tailored to the patient's wishes and holistic needs. However, typically, local disease is managed with laparoscopic surgical resection with adjuvant chemoradiotherapy. Metastatic disease involves surgical resection of any symptomatic bowel lesion or systemic chemotherapy alone. Complications of colorectal carcinoma include peritoneal carcinomatosis, which is often a terminal feature where metastatic seeding has developed in the peritoneum. Management of peritoneal carcinomatosis involves cytoreductive surgery and intraperitoneal chemotherapy. However, at this point, the prognosis is poor. Surgical management options are dictated by the location of the lesion in colorectal carcinoma. This image demonstrates at which locations which surgical procedure would be performed, with right-sided large bowel lesions being managed with the right hemicolectomy, left-sided lesions with the left hemicolectomy, and those involving the sigmoid or the rectum managed with a sigmoid colectomy or a low anterior resection. Moving on to question 7. A 62-year-old man has sudden tearing retrosternal pain radiating to the neck and the jaw, with nausea, lightheadedness and agitation. He has hypertension and high cholesterol, managed with ramipril, amlodipine and atorvastatin, and has smoked 20 cigarettes a day for 30 years. His pulse is 131 beats per minute. Blood pressure 178 over 103 millimeters of mercury in the right arm and 143 over 78 millimeters of mercury in the left. A CT abdomen is shown on the right hand side. Which is the most appropriate management? A. Endovascular aortic stent implantation. B. Intravenous labetalol. C. Intravenous fluids. D. Morphine. E. Open surgical repair and graft implantation. I'll just give you about 30 seconds to think about the correct answer. And here, the correct answer is E. Open surgical repair and graft implantation. And we'll go through the reasons why in the following slides. In this question, the underlying diagnosis is an aortic dissection. An aortic dissection is a tear in the intimal aortic layer, with hematoma formation in the intimal medial space, and progressive wall dissection with accumulation of blood in the false lumen. Risk factors for aortic dissection include acquired risk factors such as hypertension, atherosclerosis, trauma, vasculitis, and cocaine use. Hypertension is the most significant risk factor. And congenital risk factors including connective tissue diseases such as Marfan syndrome and Ehlers-Danlos. Aortic dissection presents with sudden severe tearing chest pain which radiates to the neck, back and abdomen. Hypertension or hypotension, often asymmetrical blood pressure readings between the arms with a wide pulse pressure, and presyncope or syncope due to reduction in cerebral blood flow. A wide pulse pressure results from aortic valve insufficiency with regurgitant flow into the left ventricle, so that the blood ejected during systole returns during diastole. This increases the systolic pressure and decreases the diastolic pressure, resulting in increased widened pulse pressure. Aortic dissection is classified based on the location of injury. The Stanford classification describes type A dissection as those involving the ascending aorta, which may have retrograde extension to involve the aortic root, but also progress to involve the arch and descending aorta. And type B dissection, a tear in the aorta beyond the arch, which usually present in the descending thoracic aorta, which may progress downwards to involve the abdominal aorta. CT angiography is used to diagnose aortic dissection, and here we can see clear evidence of an intimal dissection flap with aortic dilation and hematoma affecting both the central ascending aorta and the retroperitoneal descending aorta, seen over the left-hand side of the CT image. The management of aortic dissection relates to the classification of injury. Type A dissections are immediately life-threatening and are managed with emergency open surgical repair and stent grafting, which is often a hybrid case involving both cardiothoracics and vascular surgery. In type B dissection, conservative management with medical therapy is trialled in the first instance. In the hypertensive patient, this involves intravenous fluids with a target blood pressure of above 70 millimeters of mercury. In the hypertensive patient, intravenous labetalol to reduce the blood pressure to a target of between 100 and 120 millimeters of mercury. Pain management with opiates is important, and in type B dissection, if complications develop such as end-organ ischemia, aortic rupture or significant dissection expansion, endovascular repair with stent and graft placement can be considered. Moving on to the next question. A 27-year-old woman, 3 weeks postpartum, has 4 days of worsening right breast pain, swelling, redness, and pain when breastfeeding. Her temperature is 38.3 degrees C, pulse 127 BPM, and blood pressure 117 over 91 millimeters of mercury. There is a fluctuant tender mass in the right breast with surrounding edema and erythema, which you can see in the image below. Which is the most likely diagnosis? A blocked milk duct, B, a breast abscess, C, breast cancer, D, breast cyst, or E, a galactocele. So I'll just give you 30 seconds to think about the correct answer. For this question, the correct answer is B, a breast abscess. A breast abscess describes a localized collection of pus within the breast tissue. This is a severe complication of mastitis. Breast abscesses most commonly relate to Staphylococcus aureus infection. This is in contrast to mastitis, which can be infective but also inflammatory in nature only. Symptoms of a breast abscess include a history of recent mastitis or previous breast abscess, fever and general malaise, a painful swollen breast lump, and breast redness, heat and swelling. On examination, there may be a fluctuant lump with overlying skin discoloration. Breast abscesses are diagnosed on ultrasound, which will show irregular hyperechoic lesions with potentially inflammatory lymphadenopathy, as seen in this image. Management of suspected breast abscess includes urgent hospital referral and, following confirmation of the diagnosis, drainage with fine needle aspiration or incision and drainage. The fluid in the abscess should be cultured to guide antibiotic therapy, which is typically with initial empiric flucloxacillin, which targets Staphylococcus aureus infection, and patients are advised to continue breastfeeding if possible, with the support of regular analgesia. Question 9. A 51-year-old man is acutely breathless after 12 hours of severe upper abdominal pain, nausea and vomiting following an alcoholic binge. He drinks 2 bottles of rum a week. His temperature is 38.2 degrees, pulse 144 beats per minute, blood pressure 91 over 73 millimeters of mercury, respiratory rate 32 breaths per minute, and oxygen saturation 91% on breathing air. He has epigastric tenderness and guarding with diffuse crepitations across the lung fields. Which complication has he likely developed? A, acute pulmonary edema, B, acute respiratory distress syndrome, C, aspiration pneumonia, D, esophageal perforation, and E, a pulmonary embolism. So I'll just give you 30 seconds to reread the question and think about the correct answer. So this is a challenging question as it requires both determination of the underlying diagnosis and then the subsequent complication that has developed, as seen on the chest x-ray. And the correct answer is B, acute respiratory distress syndrome. The underlying diagnosis in this case is pancreatitis, which describes acute inflammation of the pancreas. Acute pancreatitis most commonly relates to gallstones or alcohol excess. However, a popular mnemonic to remember the other causes is I get smashed, which is shown on the right-hand side. Symptoms of acute pancreatitis include acute, sudden upper or generalized abdominal pain, which is severe and constant, commonly radiating to the back, and is described as worse lying flat and improved on leaning forward. Severe nausea and vomiting are key features. The diagnosis of pancreatitis is made with a combination of characteristic abdominal pain, elevated pancreatic enzymes such as amylase and lipase, and imaging findings suggestive of pancreatitis seen on ultrasound or CT imaging. It's important to note that amylase and lipase are sensitive but not specific markers for acute pancreatitis and can be ranged in a range of other conditions including small bowel obstruction, gallstones, perforated pectoral ulcers, or recent ERCP. Furthermore, the degree of elevation of pancreatic enzymes does not correlate with severity, and both may be normal in acute exacerbations of chronic pancreatitis. Ultrasound is commonly used to confirm the diagnosis, however is not typically required. Supportive findings of acute pancreatitis on ultrasound include an enlarged hypoechoic pancreas with peripancreatic edema and fluid, and in biliary pancreatitis there may be demonstrable cholelithiasis or sludge in the gallbladder and a dilated biliary tree. Ultrasound may also be used to evidence complications including pancreatic pseudocysts or walled-off necrosis. In this ultrasound image, we can see an enlarged hypoechoic pancreas with surrounding hyperechoic peripancreatic fat necrosis, marked as F on the image. The management of acute pancreatitis involves emergency hospital admission and goal-directed intravenous fluids, with initial resuscitation to achieve hemodynamic stability, and then a target of 250 to 500 millilitres of fluid per hour until the pulse is less than 120 beats per minute and the urine output over 0.5 to 1 millilitres per kilogram per hour. This flowchart provides an overview of the management of acute pancreatitis, involving AT assessment and resuscitation with fluids and oxygen if there is respiratory distress, sending for pancreatic enzymes, however not waiting for further confirmation of the diagnosis with blood results or imaging confirmation in hemodynamic stability. Fluid resuscitation is the cornerstone of management, followed by urgent surgical review with admission for treatment including early enteral nutrition, investigation and treatment of the underlying causes. Severity should be calculated and early ICU referral considered to reduce mortality. The severity of pancreatitis can be calculated using the Glasgow IMRI score. This involves laboratory values and can be remembered by the pancreas mnemonic. Scores are given for the following criteria: a PaO2 on an arterial blood gas of below 7.9 kilopascals, age over 55 years, neutrophils with white cell count over 15 times 10 to the 9, hypocalcemia below 8 milligrams per deciliter, raised urea above 16 millimoles per litre, elevated LDH or liver enzymes, hypoalbuminemia below 32 grams per litre, and a high glucose of above 10 millimoles per litre. Scores over 3 suggest a high mortality risk and a high likelihood of requiring ITU management. Complications of acute pancreatitis include local complications such as pancreatic necrosis, pseudocysts, abscesses, fistulae, thrombosis, or hemorrhage. In this CT, in CTA, you can see a pseudocyst with an usonate process of the pancreas with a round, thick-walled appearance, and in B, you can see typical walled-off necrosis, which commonly develops 4 weeks after the onset of severe acute pancreatitis. You can see heterogeneous enhancement and small pockets of air formation around the fluid collection. Systemic complications include multi-organ failure and sepsis, acute kidney injury, and acute respiratory distress syndrome, which was the correct answer in this case. ARDS describes the acute inflammation of the lungs following pulmonary damage, typically following significant systemic inflammation and release of inflammatory mediators, which can develop in pancreatitis. Symptoms include acute dyspnea, hypoxia, and diffuse bilateral pulmonary infiltrates. The management of ARDS involves oxygenation to prevent hypoxia. However, intubation and mechanical ventilation may often be required. Management of the underlying cause is essential to prevent significant pulmonary fibrosis and death. Development of ARDS and acute pancreatitis is a significant predictor of mortality. Moving on to the final question. A 65-year-old woman has 10 months of progressive chest tightness and breathlessness on exertion, with dizziness and 2 episodes of collapse. She has atrial fibrillation and high cholesterol, managed with bisoprolol, apixaban, and atorvastatin. Her pulse is 75 BPM, blood pressure 129 over 98 millimeters of mercury, respiratory rate 17 breaths per minute, and oxygen saturation 98% on breathing air. She has an irregular pulse with a harsh systolic murmur over the aortic area and an early systolic ejection click. Which test is most likely to confirm the diagnosis? A. Chest X-ray, B. ECG, C. Myocardial perfusion scan, D. NT-proBNP, or E. A transthoracic echocardiogram. So I'll just give you 30 seconds to think about the correct answer. And here, the correct answer is E, a transthoracic echocardiogram. The underlying diagnosis in this case is aortic stenosis, which describes narrowing of the aortic valve, typically resulting from aortic sclerosis, calcification, and valve fibrosis. Risk factors for aortic stenosis include age, atherosclerosis, hypertension, diabetes, and CKD. However, congenital bicuspid valves and rheumatic disease are also contributing factors in some cases. Symptoms of aortic stenosis involve SAD, syncope, angina, and dyspnea. Signs include an ejection systolic murmur heard loudest in the aortic area and radiating to the carotids. NICE recommend that those with suspected aortic valve disease should be referred for echocardiogram if they have signs such as peripheral edema, symptoms such as angina or breathlessness, an abnormal ECG, or an audible ejection systolic murmur with a reduced second heart sound. The management of aortic stenosis for those with symptomatic or severe disease is aortic valve replacement or repair, with surgical aortic valve replacement in young patients with a low surgical risk, and a transcatheter aortic valve insertion, or a TAVI, for patients with a limited life expectancy. Management of comorbidities, such as hypertension and diabetes, is also essential. Here we can see an overview of the steps of aortic valve replacement surgery. On the left-hand side, we can see open surgery where an incision is made in the ascending aorta, exposing the valve, which is then excised and the replacement valve implanted and secured into place. And on the right-hand side, the steps of a TAVI, where a catheter is inserted via the femoral artery, with balloon valvuloplasty performed, which expands the stenotic valve, followed by a collapsible replacement valve inserted via the catheter, which is then expanded to replace the valve. catheter is then removed and the prosthetic valve remains in situ. Following aortic valve replacement surgery, lifelong anticoagulation may be required. So thank you guys so much for listening to this webinar on high-yield UKMLA surgical topics for medical finals. We've covered a lot today involving perianal abscesses and fistula, aortic aneurysms, appendicitis, hernias, obstruction, colorectal tumours, aortic dissection, breast abscesses and mastitis, pancreatitis and aortic valve disease. I hope this webinar was useful, and I hope you will join us for subsequent webinars in the series which will cover other core topics of the UKMLA finals. Thank you!